the remaining people also, because this is my last chance to see you. I mean, no, not exactly at this course. Thank you. Thank you for all the videos being switched on. Very good to meet up with all of you. I wish we had more time, but senior is very strict, and that if I keep encroaching on your time, senior will be very abrupt in throwing me out. So I have to get into the subject straight away. But with one question. If you are asked to describe palliative care in a brief sentence, not more than 10 words, how will you describe it? The essence. See, this is what is called the elevator pitch. The elevator pitch is something where when Amit Siju or Joshi Jonas gets into a lift in Mumbai, in a big hotel, and you meet Amitabh Bachchan on the lift, and Amitabh Bachchan asks you, "Hey, what do you do?" You have to explain before the lift gets to Amitabh Bachchan's floor. That's what's called an elevator pitch. Quick. So would you like to put it on the chat box? What you think is about palliative care? Pain-free living. Sarita, thank you. Improving quality of life of patients and reduce their total pain. And Sarita, when you said pain-free, possibly you meant the concept of total pain rather than just physical pain. So reducing total pain and improving quality of life and maintaining quality of life, as Tanvi says. Musabiha says relief from suffering with assistance, managing quality of life, Ahmad. Walking with someone, Sundar says, in need from diagnosis, sickness, till death, and with family beyond that. Helping the suffering, live with dignity, Joshi Jonas says. Humanistic integrative approach aiming to deep listening the patients and family suffering and help them alleviate it. Care and support for the ailing. Addressing physical, psychosocial, and spiritual suffering of patient and family in all chronic and life-limiting illness. Samir. So this is for those with chronic or terminal illness. Okay, I will address these two responses from Samir and Hadassah. Till now, I agreed with everything totally. I agree with you, Hadassah, and Samir also, but I have some concern there. If my suffering is not chronic, by chronic, what we mean is not severe. Chronic means slow onset and prolonged duration, long duration. Usually, if suffering ends within 3 weeks of resolution of illness, we call it acute, and if prolonged, chronic. So please be careful with the use of that word. When you use chronic, it means only long term. That means if it is a crush injury that I have had in my chest, and I am admitted to hospital, and I am suffering intensely, ordinarily that doesn't come in palliative care. But you find me sneaking away and trying to jump out of the 5th floor window because I cannot bear this pain. I'm not exaggerating. One of my colleagues tried to jump out of the window when she had a urinary colic because it was so agonizing. So will you say, hey, you don't have a chronic illness, you don't qualify? So what I mean is, while you're totally right, that in the majority of cases it is chronic, not necessarily. Okay, that's just about the word chronic, and not only in terminal illness, had as a chronic or terminal, he or she, sorry. Yes, caring, caring with compassion at end of life. Only at end of life, Chama. If I am living with an illness for 3 years, will you come and help me only in my last few days? Certainly not, Chama. Let us make it very clear. I am glad we brought all this out on the last day at least. That is not a criterion. Certainly, it is very important at the end of life, but not only at end of life. As long as I am in suffering, I want you to hold my hands. I want you to be there for me. Thank you very much. So I think that's good enough. We have a good list. We have made the only important points that needed to be made. And so far we are doing very well. Okay, but today's session is only about end of life care. And that's rightly so. See, when I did my MBBS and then a post-graduation, all those years, we were learning to diagnose diseases and treat diseases. And when I finally qualified and went out into the wide world, I know there are several doctors in the group. Their experience must have been similar. Nobody taught me how to care for the dying. I did not know. I was mortally scared. Actually, it was a nurse who taught me at least to fill the death certificate form. Apart from that, I had no schooling. Now, you know, in this group of 37 people, there must be at least 10 people who have lost their loved one. I'm not asking for the identification, but I am making a guess that many of you would have had that personal experience of losing a loved one. And each one of you who have gone through that experience will agree with me that the time surrounding the death, before and after, are possibly some of the worst days of your life, your whole life. I know not for everybody. There may be even people living with chronic pain in this group. But for the majority of us, that's a dreadfully difficult time. And because of that, we need this education in end-of-life care. Hey friends, let me give you some good news. From 2019 onwards, the medical students have that in the curriculum. End-of-life care and pain management, end-of-life care, communication, etc. are finally in the curriculum. So I can hope that if I manage to stay around for some more time, then I may have some doctors who will have learned how to do this. And it is finally in the nursing curriculum also. That's great news. But with that introduction about where we are, let me go on to a little bit of discussion on end-of-life care. Let me share my screen. I'm sorry. One minute. My apologies. I got the wrong presentation on the screen. So let me open it. Senior will share my presentation with all of you. Okay, Senior, thank you. And in the title slide, you see a link. In that link, I have put in the link to a Lancet Commission report on the value of death. Oh, this particular link is to introductory video on the Lancet Commission report. When time permits, please take a look at it. Introduces the subject very well. In your communication session or some session, you must have come across this, right? Elizabeth Kubler's description of the stages of grief. Did you have some? Yes. So one thing about the end of life is that the patient and family must be in a mental state which is likely to be one of these or more. They may be in denial, they may be in a very angry with God, angry with fate, angry at you because you are conveniently available where God is not available to shout at. They may be bargaining. Even at this stage, the family may be trying to shift me to another more expensive hospital. They may be very sad and refusing to talk to you. Or the healthiest of all, I may be in acceptance. But please make a note that once you have gone into acceptance, doesn't necessarily mean that you will be there all the time. Has anybody read the book by Paul Kalanithi called, what is Paul's book called? When Breath Becomes Air. It is a book worth reading, friends. Paul Kalanithi's When Breath Becomes Air is a book written by this 41-year-old neurosurgeon who, during the last 1 year of his life, when he was diagnosed with cancer, when his career ended, everything ended, life was ending, he says, I went through all these stages in reverse order. He could straight away get into acceptance. But he went through all these at some time or other. So your patient, even if he or she was in acceptance last week, today may not be. So every day at this rapidly changing background of end of life, a fresh look at where the person is in terms of acceptance will have to be gone into. We will start by assuming that he could be in any of these stages, even if he was in acceptance earlier. And then it's up to us to sit down with the person, lay a hand on the hand, and give the person company. Maybe just being silent for a while, being there till the person is ready to talk. But arising from that, let me ask you, are you able to think of your own death when you are hale and hearty, healthy? You want to put it up on the chat box? Yes, no, not sure. One of these. No, yes, yes. sometimes. Yes. I mean, like you have, okay, I could wait, but not necessary. You have already shown that it is variable. We are here discussing end-of-life care. And this is an exceptional group, not a typical cross-section of society, where more people will be saying no. Mr. Joshi Jonas says, difficult to contemplate. That's typical. In an audience, if I ask, 1/3 of people are likely to say yes. About 1/3 of people will say no. And about 1/3 of people will be like Mr. Joshi Jonas, not quite sure about where we are. Well, this is a difficult subject, that kind of thing. But what I am stating is, I will not force anyone into anyone a discussion about your own death. But let me tell you, better think about it, if you can. Because in Bhutanese culture, Bhutan is all Buddhist culture. And there, everyone is supposed to think about one's own death 5 times a day. And also remember, till they were invaded by modern civilization and alcohol consumption at the turn of the century, in the 1990s, they were first in the world in global happiness index. They were not the richest, but we believe that this is what they achieved. Thinking about one's own mortality. Okay, I will have to go someday. Telling yourself that repeatedly allows you to value life and to live meaningfully. It will help you to help others who are facing death. If you are not able to handle the thought of your own mortality, you may find it hard to help somebody who is in the last stage of life. And if you think about it, you will be able to die as well as possible because you would have plans made. Sarita, Vaishali, and Preeti, and Samir, Sunita, who all said an emphatic yes. You are able to think about it. Therefore, you are able to make some plans. In our website, if you go to resources, you will find in the end-of-life care section, advanced directives. It's good to talk about it within the family. I have my own experience in my own family of discussing that. Help my own brother-in-law to die a very painful, prolonged death in the ICU when he had a neck fracture. So we'll maybe able to make plans. And if you know that you will die someday, then you will be able to value not only life, value relationships. You will see how precious is the time we have. And rather than spending time on meaningful things, you will learn to nurture relationships. So before talking to patients, because we are going to be patient someday, our loved ones are going to be patient someday. Let us talk about this also. Even the young people, I would encourage you to talk about this and think about it. Shall I wait a minute for any comments? Siju is looking intently at the screen. Siju, you have a question or a comment? You have a question?
Nothing, sir. It's, I was, a bit surprised with this fact about contemplating your own death. I was thinking about it. That's it.
Sir, I would like to say something.
And sorry, what's your name?
My name is Preeti.
Okay, yes, Preeti.
Yes, it's very difficult to accept the fact that all of us are going to go one day.
Mm.
But as it's one of my teacher told me this once, that it's required for you to remind yourself every day that we're going to go one day.
Mm.
That helps you to live the day to the fullest the whole day. The
Mm.
reminder that we are going to go, that
Mm.
the mortality of this life is very important for each person, though it is difficult to accept, but that reminder helps to fulfill the rest of our task. That's what one of my teachers shared one day, and I thought I'll share with you.
Preeti, thank
Yes.
you. That's profound. Devashish, do you find it a bit tiresome that Preeti is all the time talking about death?
No, nothing like that. I share the same thoughts.
Okay, Devashish. Thank
Yeah,
you.
she's speaking for me as well. Thank you.
Hey, and here is a look at the smiles. Both of them are so happy. Everybody, anybody wants to ask them some question? And thank you, Sunita. You said the certainty of death makes us want to enjoy the present of life rather than spending that time at meaningless quarrels, going on ego trips. Thank you. Shall I go on if there are no other comments? This is how the Indian Council of Medical Research describes the duty of a healthcare provider. The duty of care of a healthcare provider is to mitigate some suffering. It is to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. Although I have put in bullets, these three sentences, one following the other, is the definition of the duty of care of a doctor, of a healthcare provider. Senior, please make sure that you send the PowerPoint to everybody. Thank you. And friends, this ICMR document is available for free access. And please look at least the executive summary. It's about end of life. It will define the terms. But arising from that, let me go back to the first question that I asked you. Your elevator pitch to Amitabh Bachchan about what is palliative care. To me, it is mitigation of serious illness-related suffering. And every other answer is correct, and to improve quality of life. So mitigation of suffering is our primary duty, and not only when they are walking around, that mitigation of suffering, that's comforting. That is our duty even during the end of life. Unfortunately, India is not a good country to die in. I don't think I have put in a slide there, but in 2021, the Lion Foundation published the Quality of Death Index. In the Quality of Death Index, that's actually ranking the end of life care. No, sorry. Preeti, I see you looking intently at the screen. This is not what I have. Let me take this off. What I'm talking about is not what I have on the screen. I broke a good rule. This economist, sorry, the Lion Foundation Quality of Death Index, which ranks the quality of life of various countries, puts India among the worst, 1/4. I think it comes 59th among 81 countries. And our neighbors, thankfully, Bangladesh, Sri Lanka, I don't think Bhutan is ranked in that. These countries are doing better than India. So we are not in a good place, and I'll explain why we are not. This is what Dr. Sankha Mitra says. Dr. Sankha Mitra is a British oncologist who does charity work in West Bengal and in Northeast. He says, in India, the poor die in misery of neglect. The middle class die in misery of ignorance. The rich die in misery on ventilators. See, this woman was an exception. She was dying of advanced cancer, but she got her daughter, to very poor woman, to come over to the destitute home that she was in, lay a hand on the forehead, and lovingly pour a bit of water into her parched throat. This is a luxury in India. That pain relief, if the pain relief is not possible, the agony is horrendous. That's how the poor die in misery. The middle class don't know what to do. They rush from hospital to hospital, bargaining for a cure. And the rich would go on ventilators and die the worst kind of deaths. I say this is the worst kind of death because you have a painful tube in every orifice, particularly the one down the trachea is agonizingly painful. And then you try to pull the tubes out and see they tie your hands and feet. My God, you don't do it, even do it to the people, prisoners who are sentenced to death. They are given more dignity than this and better quality of life. And then your dying process is stretched out to weeks. And instead of this person without palliative care, if she was without palliative care, dying in a day of suffering, he would die in the 3 weeks of suffering. Any comments, friends? Is there anybody who thinks this is not correct? Maria, sorry to hear that Brazil is with us. I wish you climb out of that. Sarita, please speak up.
Yeah. Sir, recently my mother-in-law died and she was in the hospital with, with drips and all that. And every time she would take it off. So we are not sure whether, now I'm thinking whether we should have made her gone through this, or was it okay to just let her be? Although if
Sarita.
we feel that, she needs treatment in the hospital, but she has dementia and she was doing all this. It's just for, I don't know whether I've done right or wrong. So I'm just asking you.
Sarita, I'm sorry to hear this. I'm sorry to see you suffering even now. And I'm sorry, particularly sorry, that my discussion is going to make your suffering worse. Because I am making you relive your horrible memories. And whatever you had done, you would feel guilty. That is human nature. If you had not done it, you would have thought, oh my God, I deprived my mom of essential care. So while saying that, in dementia, doctors give intensive care and intravenous infusions because they don't know what else to do. Palliative care was not taught to people like me, so I would have done the same thing if I had not chanced upon palliative care. So, Sarita,
Yes.
In future, after this session, we will think about how we can make it better for any surviving relatives and yourself. Samir, yes, you are muted.
Yeah,
Samir.
yeah,
Okay.
doctor. So what I have noticed that, even when the patient is in like end of life stage, it's the family definitely wants, like, they'll put the patient on ventilator, prolonged suffering. That's one way of looking at it. And And yeah, so the relative wants them to live as long as is possible. Sometimes doctors want to do that, and you yourself acknowledged it, and when you were answering Sarita, and and especially more in children, and even as a care givers, social workers or counselors, you know, it's something in me at least feels, even although at one part in me knows that okay, putting on ventilator is prolonging suffering, but something in me also sort of feels guilty for not giving, like it feels like wrong to although I'm in palliative care. So I don't know, I think you can sort of give a better perspective of how to sort of process our own guilt to, yeah, I don't know
Samir,
whether, yeah.
you made yourself very clear. Thank you.
Hmm.
This is something that we'll talk in a bit more detail. Now, presently,
Hmm.
we'll talk about it. But let me also clarify that if you allow that prolongation of the dying process in a loved one, that's out of love, right? You are allowing that person to be on a ventilator for 3 weeks because you love that person. You don't want to let go, right?
So that actually contradicts with what I learned yesterday. So Elizabeth Kubler-Ross says that says that even saying no is love.
No,
In one of, so I really
absolutely.
don't know what is love now.
Absolutely, Samir. That's love. This is also love.
Yeah,
When I feel I can't let her go.
yeah.
I need her. Mom, I need you. I don't want to live without you. That's love. The other is, my poor mother is suffering so much. If it is time for her to go, let her go. The former Samir says selfish love. You are thinking more of yourself. I don't want to let go. I want her in my life. The other is a less selfish, more selfless love, where you put that person in the first place. And you don't ordinarily think about it, but this is something that we need to resolve within ourselves. And as you mentioned, some of children, and with your elderly mom, it's easier to let go. When it's your own child, I can't let that my son go. And especially in Hyderabad, there's an oncologist by Dr. Sudha Sinha. She published a paper about 4 years back or so. She found that children with leukemia, when she studied them, 50% of them had received chemotherapy in the last week of their lives. That's atrocious. Okay, some will be inevitable. You don't know that things are going wrong. But 50% in the last week of life, and even those parents, if we give them enough time and counseling, may accept, my poor thing, he is suffering so much. I'll bear my pain, let him go. That's selfless love.
Yes.
Samir, this is something we'll have to ponder within ourselves. When you love your partner or your kids or your parents, what kind of love are you going to give them? Will you think more from their side or from your side?
From their side is the more pure love, right? Which is not sort of binding. It's more of a sort of freeing kind of. Yeah. So thank you for that definition of self, other, love. I mean, it clarifies things.
Okay.
Yeah.
No, these are tough areas, not usually talked about. So when we think about end of life care, and this is an extension of the answer to your question, Samir, we have to decide that the objective is to keep the person as comfortable as possible, physically, emotionally, socially, and spiritually. and particularly to the doctors in the group, very often we think that we have a duty to prolong life. It's an unwritten rule that we have learned somehow, that you have a duty to sustain life. And how do you define life? Is just a beating heart. And because of that misconception, no, I'll emphatically say, you will not find that in a textbook of ethics. You will not find it in any law book. You will not find it in any textbook of medicine. That you have a duty to prolong the heartbeat as much as possible, even at the expense of suffering the person. There's no such thing. This is your duty if somebody is very clearly dying of an incurable condition. I know that there will be some situations where you are not sure. Then we let continue. But when we are sure, especially the person with dementia, especially the person with advanced metastatic cancer, we look from their side and concentrate on their comfort. I know that some of you who have gone through that experience will be kicking yourselves and going on a guilt trip. That's unavoidable. But I think we need to be brave enough to think about the future. Let go of some of those guilt feelings that you are living with now. But that's not easy, I acknowledge. So let us make, let me read it once more, because I want this to be very clear in everybody's mind, that when my time comes, if one of you is caring for me, I will consider myself very lucky if you accept this, that your primary responsibility is not to deal with your own emotions. Your primary responsibility is for my comfort, physical, emotional, social, spiritual. If you don't give palliative care, if somebody goes without palliative care, the person dies in pain and symptoms, in psychosocial suffering, disconnected from their own world. They have no connections anymore. You are not keeping them in our world. It's a different world of tubes and machines and alarms. And there's no meaning to life, their life. Life is not just a meeting hour. It's a life with some meaning to it. And the family lives with memories of suffering. The pain that you saw on Sarida's face, and that pain suffered by several people in the room, will be the memories of the suffering that the person went through and the guilt. Instead of that, if we provide palliative care, the person will go with physical comfort, will feel connected to you, your loved ones. And even if the time is limited, it will be a meaningful. If on the last day, my last day, I want to see my son once more, and if he will be allowed into my room, that's so precious to me. If he is shut out in outside the ICU, he is in pain, I am in pain. And there will be grief, even if the person dies reasonably well, there will be grief. But after some time, even though with grief, you may be also able to think of the smiles you have shared together, the time that you have enjoyed together, the time you spent her birthday or took him or her out on the beach, and those things will be coming to your mind, and not only the pictures of suffering. You would value the relationship that you have had with the person and the satisfaction that we have given them our best. So this is what palliative care can do at the end of life. A few practical things as family members or as caregivers, as palliative care professionals or volunteers. One thing that we ask everyone to do, even if the person is apparently unconscious, to continue to talk to them. When unconscious, you never know when they are feeling something. If there is a grain of consciousness in there, who knows? They may be able to feel your loving touch and hear your words. When you visit our institution, you will find that even if somebody is unconscious, before turning them over to the other side, our nurses will say, "Uncle, maybe shift you to the other side. I am bending your legs. I am turning you over." And this is important for the person, possibly, maybe not important. It's important for the family to feel that their loved one, even if unconscious, is being treated with dignity. It's vitally important. And that health and emotional needs of the family should be taken care of, particularly of children. And if the family, the person is religious, religious rights should be facilitated. Most of these things on this slide, you don't need to be a professional. You only need to be a human being. And those are precisely everything that will be systematically stolen from me if I am shut up in an ICU. Hey, this is from an article published by the former, this gentleman, Parthasarathi Show, was the advisor, financial advisor to Prime Minister Manmohan Singh. And after his watching his mother for 5 minutes in the morning and 5 minutes in the evening in an ICU, he writes this. Would somebody like to read it out for me? Volunteer to read out what you see on the screen.
Even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was in the negative.
Okay. The last day, in an incurable condition of the liver, they still want to repeat the liver function test. Why on earth? Dear doctors, why do we keep on doing these things even when we know that the person is dying? Another poke into the arm or multiple pokes because you can't get a vein. Just to know whether liver is okay. What are we treating? Are we treating the human being or are we treating only the liver? I mean, I have given the link there. When you get it, if you Google and if you just open the link, you can read the whole article. And this is very common. Even when the person is on his last day or her last day, they very often get a multivitamin tablets, cholesterol medication, and those things have no relevance. Invasive procedures have no relevance. And particularly think of children. Senior, how much time do I have now?
Sir, we have half an hour for discussion and 10 more minutes for presentation, sir.
So no case presentation today.
No, sir.
No, good. Friends, this is something that you can do for others. You must do for others. Ordinarily, when there's a serious end-of-life situation in the family, children are forgotten. They are asked to go out and play. We had a visitor from America once, and later she explained she had wandered all over the world looking for answers. She had watched her mother getting progressively ill and eventually dying at the age of 10. Nobody explained anything to her. And after this, she went into a related field. She's not a medical person. She went into narrative medicine, generally working on issues like this. Children will be traumatized and scarred forever if their questions are not answered, especially if children become the caregivers. This child was in a very bad shape, screaming away in pain, and the mother had gone off out of her mind. She had developed a depressive illness and couldn't function. The father was all the time running around trying to find money for their food, and he had lost his job. And this girl was the main caregiver. What all trauma she must have gone through. So, whether they are caregivers or not, please remember, children need explanations depending on their age. Till the age of 5 or 6, they cannot understand the finality of that. If you tell them, dad has died, they will escape. Okay, when will he come back? But from after the age of 5 or 6, they can understand. That's the time when their behavior may get modified forever. They need compassionate disclosure of truth and support to go through the rest of their lives. Adolescents then have to deal with the adolescents as well as with the trauma. They need support too. This is another article that I would encourage you to read, written by a journalist writer by name Sindhu. Sindhu, yes. Who is going to read it out for me? A different person this time.
Should I read, sir?
Yes, please.
My 84-year-old father, my best friend, was enduring raw, intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonist.
So when you find the times, read that this reality that's happening around us. Now, interestingly, there is agreement that this is wrong. National Cancer Grid is an organization of collaborative of more than 300 cancer organizations in the country, led by Dr. Pramesh, who is a director in Tata Memorial Hospital, Mumbai, and the CS Pramesh. And this group has come out with what should be avoided. And this is what they say about cancer. Do not treat patients with advanced metastatic cancer in ICU unless there is an acutely reversible event. Advanced metastatic cancer should not go into the ICU. They should be getting compassionate care with the family. But you know what's happening. Even the members of the National Cancer Grid continue to do it because they don't have palliative care. They don't know of an alternative. And many doctors particularly believe that if you withdraw the ventilator, say, Sarita, in your mother with dementia, if some form of artificial life support is withdrawn, like a ventilator or like artificial feeding, is it euthanasia? Again, very clearly the ICMR definition of terms that I requested you to read the executive summary says withdrawal of artificial life support is not euthanasia. Euthanasia is mercy killing. It's still killing, deliberately ending life. Withdrawal of artificial support is only allowing natural death. You stop the ventilator and a person may die. He would have died a natural death. The term passive euthanasia, which is very often used, is a misnomer. There's no such thing as passive euthanasia. Euthanasia cannot be passive because euthanasia is killing. And this is what we are doing, allowing natural death instead. When a cure is not possible, when retaining a quality of life is not possible. So, considering the grave risk that I will be running when I eventually get ill, my wife and I have written our own advanced directives. Advanced directive is otherwise called living will. India does not have a law covering this. Therefore, a Supreme Court judgment of March 2018 stands as valid. In the absence of a law, a Supreme Court judgment would be valid. This was a 5-bench judgment. It is the common man's protection against intensive torture. I have signed a document expressing what my wishes are. I have named a trusted person to take surrogate decisions. My next of kin, my wife or my sons would be the decision makers. But if they are not available, I have named a nephew to take decisions on my behalf. I have discussed this with my wife and my children and my nephew. We are all on the same page about it. According to the Supreme Court judgment, doctors, you have the ethical and legal duty to respect my wishes. If with all your good intentions, you still put me on a ventilator at that time, that is, if I am suffering from an illness from which I am unlikely to make a recovery, and if 3 doctors together have agreed that that is the way it is, then you have a responsibility to respect my wishes. This judgment is also available for reading, but that's too long. But our Parliament's website, in the resources page again, gives the advanced directive form. The Supreme Court order has several positives and negatives. Though the government of India had started on creating a law in 2016, they did not make progress with it. Therefore, this judgment is valid, which validates advanced directives. It validates withholding and withdrawing life support. But to validate the advanced directives, the Supreme Court judgment puts in an impractical and complicated process. They are reviewing the judgment as of this week. And the Supreme Court judgment also called withdrawal of life support passive euthanasia. These are the negatives. Confusion is there. But let me tell you, the more important thing, rather than writing the advance directive, discuss it within the family so that everybody agrees. Even if I have signed the document, even if it is legally valid, no sensible doctor will follow it if my family doesn't permit it. Because everybody knows that dead people do not take you to court. Living relatives take you to court. They would, if they are sensible, they would follow the relatives' wishes. That's the reality. And therefore, more important than writing the advance directive would be discussing that with the family and making sure that everybody is on the same page. And I'll repeat, the duty of care of the healthcare provider is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exception to this rule. Earlier this year, the Lancet Commission on the Value of Death published their report, and they made the following recommendations. The management of suffering should sit alongside extension of life as a goal of healthcare services. Management suffering is a goal. Extension of life is a goal, so long as it's of reasonable quality. Education on death and dying and end-of-life care should be in the curriculum of every health and social care student and in continuing education of practicing professionals, which is what we are doing now. Patients and families should be provided with clear information about the uncertainties as well as potential benefits, risks, and harms of interventions in potentially life-limiting illness to enable more informed decisions. Information is not a luxury. Information is the right of the patient and family. And these discussions have to start early. Earlier, Samir, I think, brought up this issue. Here are the major barriers to compassionate end-of-life care. First, I will put doctors' perception of duty of care. Doctors really believing that they have a duty to prolong the heartbeat. But what Samir said is absolutely right. Unless the matter is discussed in advance, the family may say, I must do everything. He's my dad. Money doesn't matter. It doesn't matter if I go into debt. I must keep him alive. The selfish kind of love. Not thinking about how much he is suffering. The society will pressurize you. Samir, this is another issue. Even if, okay, selfless love, you are considering the person, your uncle will come. Hey, Samir, what are you doing? You don't want to spend money on him? Isn't he your own father, mother, uncle, aunt, something? They'll put pressure on you. So when we discuss this with the patient's families, we tell them, this is going to happen. If you decide that you are going to keep him at home, or if you decide that you will keep him in the hospital room but not in the ICU, there will be pressure from the extended family and from friends who will urge you to shift the person to ICU. But at that time, right now, you take a decision that you will do the best for that person, not to please an uncle or aunt, not to please somebody. And when they make up that mind, that's self-fulfillment. Of course, it would have been nice if we had a sensible law covering end-of-life care, but that's for the future, for all of you to make happen. So, friends, that's my closing slide. This discussion doesn't stop here. This has to continue. All of us have to get together, make sure that this matter is discussed, accept that there's a cruelty being perpetrated on India, in India, world over, but particularly in India, about people who are dying. And we should have a sustained, concerted effort, an advocacy campaign. Senior, we must do something about this and keep everybody engaged with this kind of thing. Friends, thank you very much for listening to me patiently. I'll bring the slides back during discussion if necessary, but till then, I'll stop.
So sorry to interrupt. I think Hadasa had something to ask a question or something. She raised her hand in between.
Yes,
Hadasa, please go.
I'm sorry, please.
Nothing, sir. Actually, the thing is, when you were talking about putting the loved one on a ventilator, when you know that the person will not, they'll not come out of the illness and it's just prolonging their, life. It is what happened in my family very recently. And my mother was sick and she was diagnosed of cancer, and then she suffered a stroke. So because of this stroke, she became unconscious. She was not even conscious. She was put in the ICU for 4 days, and then we were even given this option, let's say, by the doctor. They said we can put them on the ventilator, but thankfully the doctor, being, he was very honest and upfront about it. He said, even if we put them on the ventilator, because there was some relatives who were asking about this question, can she be put on the ventilator, can we do something about it? So the doctor said we can put her on the ventilator. First he said, do we have so much money that you just want to prolong their pain? that she'll be in the ICU, she'll be on the ventilator, you'll be just pouring in money, but we cannot guarantee that she'll get well. So do you want to see her suffer like that? So and I have some previous experiences in my family, and I know that ventilator a lot of time doesn't work. Like none of us, like my grandma and other people who were there on ventilator, they didn't come out living out of the hospital. So it was my and my father's decision that we will not put my mother through the suffering. We were as you said, in that stages of grief, we had come to acceptance first. So we had accepted that she was ill, we had accepted that it's her time to go. So we had said, no, we don't want a ventilator. It is better that, her suffering is less. We don't want her to suffer endlessly. And when this whole topic came up, I just really thought of it, that thankfully I took that decision, because like around 14 days after the whole thing happened, my mother passed away. I was even actually going to put her in a palliative care center, but even that didn't happen. And now looking back at the decision, I sort of think that, thank God, I was thinking from my mother's perspective, that I didn't want to prolong her pain, because I knew that's what it was going to do. And thankfully I had doctors also who were supporting in our decision. They didn't put any pressure on us, and we could like navigate through the situation. It's not easy, but a little bit more easier to know that my mother didn't suffer unnecessarily. So I think this is a very important conversation to have when we come into those situations, rather than, as you said, relatives come up and they say a lot of things like, why don't you put them onto ventilator, why are you not spending more money? But I think it's the patient. First of all, I was thinking for my mother, and I think I'm very happy with the decision I've taken. So thank you so much for bringing this up in this presentation, sir.
How do you pronounce your name?
Hadassa.
Hadissa, thank you. Thank you. I mean, the thing that, okay, the few things that help you on your own strength of conviction, your own and your father's decision together. But it was also very helpful that you had a doctor who was honest about it. This is not every doctor who takes that. And maybe Sunita is suffering today with the questions in her, possibly because she did not have that doctor. The doctor who could guide her to take, it's not Sunita, Sarida. Sarida did not have that doctor who could give the proper advice. So, yes, thank you, Hadassa. I am very happy that though you lost your mom, you are able to look back on it with some satisfaction that you allowed her to go in some peace. Sunita, you have raised your hand. So I read your comment on the chat box, but maybe you can read it out or say it out for the benefit of everyone. Sunita?
Yes, thank you, Dr. Rajagopal. I just wanted to comment first about what you mentioned about speaking about death in the family. I think it helped us as a family because my dad died at the age of 67. Worldly wise, he had got his children married, he had seen his grandchildren. So, you feel the milestones have all been achieved. But what helped us was when it came to taking decisions for him in the hospital, was that what he would always mention, that he would say casually as we're talking, he would say, never cut me up and keep me prolonging my life. And I think that kind of conversation I got from my father, a legacy, to be able to have that kind of a discussion and think about death, because he was very clear that he didn't want to be cut and kept prolonging his life for the sake of prolonging his life. So when we had to take decision for him, it was easier. On the other hand, recently, some months back, or closing to a year now, one of my other relatives had a serious attack at home, in terms of she held up brain and head, and she ran. They had to take her to the hospital where it was a stroke, and it was very, very sad what she was going through. But the doctors kept on giving hope to the children, and the children were not able to see the real condition of the mother, and they kept her in the hospital for almost 45 days in the ICU, when it was very evident that she would not come out of that place, to the extent that they were even willing to move her from the ICU to home for a continued, the whole ICU experience at home. And finally, just before they were getting to do that, the lady passed away. And I felt very sorry for the children because none of the relatives were in a position to speak more than what the doctors gave them hope. So the damage was multifold in their case. The expense, as well as the emotional, as well as feeling betrayed at many levels. So this discussion is so good to have today, because sometimes when you're thinking like this, you feel you are the odd one out to think that death is a reality. So we must make decisions very carefully than just, going with prolonging life. Thank you for this opportunity.
Sunita, not everybody is able to have that kind of conversations. Because you remember our opening in the session today, we had several people who did not want to think about their own death. And the question of a discussion doesn't arise. Sawal hi nahi paida hota. How can it? So this is an issue. Because then that means if my family is unable to think about it, I go through horrendous suffering for weeks together, and I have to know go with the knowledge that I have destroyed my family financially. But having said that, no, thank you very much. I have put up a link on the chat box. Senior, do you think you could copy that link and share it with the group? I'm sure you must be.
Shared it, sir.
Oh, my good God. How can I give you instructions if you do it even without telling you to? Thank you, Senior. Okay. So this is written by a non-medical person. She is writing about how she initiated the conversation in her own family. And I think it will be very interesting to read how this got done. Ahmad Al-Mantasir. You want to read out your comment to chat to everyone so that people want to hear? Only if you feel up to it.
Actually, my cousin died of adenocarcinoma lung about 8 months back, and it's a matter of sorrow and grief that the oncologist every time mentioned that you try for her till the last breath. I tried to counsel my sister's family that it's of no use, but oncologist is much more knowledgeable as regarded by the family. They go on through the chemo, radiotherapy, and unfortunately in hospital, my sister died. I think that every doctor should have a brief knowledge about palliative care.
Dr. Ahmad, sorry to hear of your bad experience. I mean, among all the specialists, oncologists are the one group who have discussed this more, even created guidelines about it. But even they are doing this. And Dr. Ahmad, you are an internal medicine person, and most specialists have not any idea about the end of life care. The new medical students will have more knowledge about this. Dr. Ahmad, at some point of time, in maybe in Association of Association of Physicians of India, API meeting or something, this desperately needs to be brought out. I know that it was made an occasional session, some conference, but usually, you know what happens? You talk about end of life care or palliative care, it will be in Hall E on the last day of the conference, at the last session, and where nobody will attend it. So, Dr. Ahmad, I hope this can happen. This needs to be discussed. This cruelty to human beings must stop. And we have to work together at it. We have to have a campaign and keep talking about it. But internal medicine people particularly, I don't know whether you are active in API, but I hope something can be done.
Sir, I'm from Bangladesh. I'm
Okay.
Bangladeshi doctor.
Okay. Which
What
city are you from?
Bogura. It's about 4 hours from the capital,
Okay.
and I'm working in a medical college.
Okay, doctor. I mean, there are several very good palliative care initiatives in Bangladesh. I have put up my email ID on the chat box. If you write to me or anybody is feel free to write to me, I can connect you to some palliative care pioneers in the country.
Thank you all for the comments and questions. If there are any other questions, suggestions, or you need any clarifications, please go on.
Musa Bihar,
Yes, sir.
where are you from?
Chennai, sir.
Okay.
Chennai. I'm a physiotherapist working
Okay,
in
Musa.
Chennai.
Okay.
So now, after the COVID lockdown and everything, I have been seeing patients who have fall, like geriatric people. They have more and more of falls and accidents. So they find it very difficult in their end phase of life, and their family members actually want them to walk and be independent, which is typically not possible for the patient. But the family members, they keep forcing, like, yes, you can try, only if you try it will happen. So in that way, when I tell them, like, this is the muscle power she is having, it will take a long time for her to walk, but they don't have that patience. So how to deal with people like this, like how to make them feel better, sir, like the family as well as the patient?
Musa Bihar, thank you for bringing that up. Which also raises one issue here. Of course, falls are common. People get fracture of the head of femur, neck of femur. And then an orthopedic surgeon would say, well, he or she is 93. What's the point? Or they may say, we can operate, but it's going to be risky. She's a high risk patient. If I am 93, I will be ready to die when my time comes. But I am not ready. I mean, I wouldn't choose that kind of death. Even if it is risky, I would like that surgery done. Because even if I am I'm living only for 3 months more, being able to walk, it matters a lot to me, even if risk. And then, Musabiha, in our country, and maybe generally in South Asia, post-operative pain relief is not very well done. Musabiha will be able to do wonders for that person if I provide the person with good pain relief. Then you can work, and you may be able to get the person to walk. Okay. So that's my first point. This can happen in any one family here. Uh, being there in the bed a few weeks while you are saying, okay, let it go into malunion, then we'll make her walk. By that time, as Musabiha says, everybody please remember this. An elderly person in bed for 3 weeks would lose muscle power so fast. Muscles would have wasted. And then they can't get it back most of the time. It means best chance would be early surgery, excellent pain relief, and a Musabiha by the patient's side for us every day. And that will do the wonders. But we are a long way away from that time. Well, Musabiha, one problem is also that while you are saying all this, there will be 7 other doctors coming and say, no, you must try. Maji, please keep trying. Don't be lazy. Pain doesn't matter. Walk. Maria, Sarita, I'll put up a link for the living will and show it to you in a moment. I don't know if you had a Maria, which country are you from? Brazil. Maria, okay, interesting. Later tonight, when this happens at 1 second. From 8 o'clock, we are doing a session. I am giving a talk for Elizabeth Kubler-Ross Foundation of Chile. And the topic is specifically on what you have mentioned there, on community participation, on compassionate communities. Maria, if you are interested, you write to me in the link given in the email ID given above. I'll give you a link to the meeting. I don't know whether it's you can register at this stage, but we'll be talking about compassionate communities in Kerala. But Maria, within the limited time we have, it may be a bit difficult to talk about that. So I'll just mention a couple of sentences. In your country and mine, and in Bangladesh, or any other country that people are in, over the last 2 generations, we have moved from extended families to nuclear families. Most problems used to be taken care of by within the family. But if the family needed help, the neighbors would drop in all the time anyway. We had that social structure, which is almost completely gone now in cities and partially dying in rural areas also. So that nuclear families are by themselves. There's no community to take care of. In the same apartment house, there will be 7 elders, all alone and bored to death. Compassionate communities are about the people who have compassion in them, who want to bring some meaning to their lives, getting together and supporting people who need support. We need Maria Alice could be that catalyst, facilitator, getting a compassionate community together. So if that thing happens, in the community that I grew up in as a child, I've seen the people dying in my home and with my neighbors. We children were part of it. Nobody told us, go away, don't come in here. We were part of it. We saw people die. We saw how the elder next door will come and feel the person's skin and say, the limbs are getting cold. You better inform all your relatives. They would diagnose the gasping breath and say, time is going to be very limited now. All that has changed. It is unfamiliar territory now. So that means here people, not necessarily the professionals or non-professionals, get together and support people around you who need help. And we all can be the facilitators for that. There is a question about the living will from Sarita. I'll just take a few seconds to find that link and give it here. I might as well share my screen as I am struggling with this. This is Pallium in their website. I've just gone to Pallium India's resources page, and now I am going to end of life care section. There. This is a copy of a living will or advanced directive. So you will see a living will and some instructions there in this page. I'll also share the link in the chat box. Please take a look at it.
Sir, I have shared the link in the chat box. You can continue now.
Senior, you are getting me absolutely frustrated. Very good, senior. You foresee, even before I ask for anything, you are doing it so good. Hey, friends, isn't it amazing to have colleagues like senior? By the time I think she gets telepathy. So, Sunita, please look at that and email me if you have any questions. But let me remind you, it is not enough to fill the form up. Talk about it and get into agreement with all your family. Yes, I agree. Senior is genius, somebody says. Senior, are you getting any feedback from the calls today?
Yes, sir. We
Okay,
are
so
collecting feedbacks for each session.
okay. But you will be giving the feedback, ladies and gentlemen. If you have any more questions on the subject, I am happy to be here. But I have one more request. Feedback, usually you are all nice people. Most people write only nice things. Isn't it, senior? Oh, very good. Excellent course. Thank you very much, etc., etc. Think of something that could have been improved. Something that you found difficult. If when senior does the next course, what should senior and I remember and my colleagues remember? What were the major difficulties that you have? Unless you have questions about end of life care, would you like to tell senior and I that?
Yeah, I like to share.
Yeah, yes, please. Sunitaji.
Yeah, I was actually wondering after I filled up the form last time, I think in a hurry, I looked at all the good things that happened in the session and I did not include this feedback, which I've been wanting to share. Last two sessions were about grieving and bereavement, and the facilitator was very mindful of the fact that it was a very heavy session and the way she conducted it and was great. But I thought was my personal experience, because some of us in the group shared about their huge loss that they went through, their grief. And so I was just thinking that maybe what could have been given time for in a session like that was to get the group to do a breathing exercise ourselves before we close out. Because I could find that my own breathing level had really increased. My space of being comfortable after the session was not a very comfortable space. So I was aware of it. So I consciously sat down and did a few breathing exercises. So that's the feedback I wanted to give, because the last session was very intense with a lot of people sharing about their personal experiences. So that's my only feedback I wanted to give through all the different sessions that we went through. Thank you.
Sunitaji, thank you very much. Senior, will you convey that to the person who did the course session? Was it Smriti?
Yes, yes.
Yeah,
Please,
please convey it to Smriti. And let us remember, if unless there are more people to say this, they give feedback, we maybe at least even today, it wouldn't be a bad idea. Remember, there are 1/3 of people who are sitting there, who are going through their guilt trip. They are going through pain. They wouldn't have spoken. But any other feedback to give? Scope for improvement.
We will also be collecting the end evaluation and
Okay.
the things.
So please include anything negative. Sunita ji, why don't you take over the session
sir.
and let us do it? We have a couple of minutes left. That breathing exercise. Would you like to take us through that?
Sure, why not? I'll do the way I do it.
Yes.
You may want to sit very comfortably, mindful of how you are sitting. If you have pen or pencil or something, just put it down. Put your feet on the ground. I call this a square kind of breathing. Be aware of how your breathing is right now. If you take a minute and count of, be doing 1, 2, 3, and 4. Count of 1, breathe in. Hold it for a count of 5 seconds. Exhale for 5 seconds. Go back and breathe in. Hold it for a count of 5 seconds. Breathe out for 5 seconds. Breathe in. Hold. Breathe out. Let's do one more time. Breathe in. Hold for 5 seconds. Breathe out. You can open your eyes. Thank you for helping.
Thank you. Thank you. Thank you so much. So friends, thank you for being interactive. Thank you for your active participation. I enjoyed the session, certainly. And I hope you will all get satisfaction from what you are going to do in this field, that your life will be, I hope your life becomes seem more rewarding and meaningful. And I hope you will be happy. Thank you very much.
Thank you, sir. Thank you so much for joining us today. And thank you all. It was indeed a wonderful journey throughout the last 16 sessions, including today's. Thank you all. And I believe that you all will spread the love of palliative care over the world. Thank you for joining us, and keep in touch. The WhatsApp group will be there. If you have any comments, anything to add on, anything else, you can talk there in our WhatsApp group regarding palliative care. Thank you all. I have shared the feedback link in your WhatsApp group. Bye-bye.
Thank you.
Bye-bye. Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you. Thank you.
Thank you very much. Thank you.
Thank you.